right, let's get started. Thanks everyone for tuning in today. My name is Patrick Chu. I'm the Policy Initiatives Lead here at ARNBC. And today our webinar is around medical assistance in dying. And as most of you know on the line, it's already been over a year since MAID became law, and throughout the course of this year, there have been significant developments. If it's the health authorities developing policies or the regulatory body developing some more regulations to guide nursing practice, there have been many changes as well as challenges. And so today I have Laurel who is the clinical nurse specialist in the assisted dying program at Vancouver Coastal Health. She's going to be a presenter. And Laurel has a background in pediatric oncology, ICU, and palliative care. She holds a BSCN from McMaster University and a Master's of Science in Nursing from UBC. And in fact, her final master's project, which she completed earlier this year, was anticipating nursing practice implications of medical assistance in dying for minors in Canada, and it was in an environmental scan and policy analysis. So Laurel has a wealth of knowledge in this area of medical assistance in dying. So just to let everyone know that you are muted, if you do want to ask a question, there is a taskbar on your right-hand side of your screen. Towards the middle portion of that taskbar is a tab that says questions. Just double-click on that and type your question in, and at the end we'll read it out loud and Laurel can answer your question. So we have about an hour dedicated to this webinar, and I will hand it over to Laurel.
Great, thanks everybody for coming. I know that thanks for carving out an hour of your day. I know it's precious, but this is a very important topic, as Patrick alluded to. Yeah. Great. So the goals of today is to provide you with the most up-to-date information about developments of medical assistance in dying across British Columbia, with a special focus within the context of nursing. First off, I thought I should also give you some definitions. We're no longer using the term assisted suicide. We're using the term assisted death because suicide can have potential negative connotations for patients. It's also interesting in Canada that we're saying medical assistance in dying as opposed to physician-assisted death because nurse practitioners are also able to assess and provide assisted dying. Also, there's some misunderstandings about euthanasia and assisted dying. In in Canada, we have euthanasia as well as assisted dying. Euthanasia is considered when a health practitioner administers medication that will end the patient's life, and assisted death is when the patient themselves takes the cocktail by themselves. So we have both euthanasia and assisted death within Canada. So our objectives that we have for the next hour is to understand the changes of the criminal code and how they came about, as well as discuss the eligibility criteria and process for medical assistance in dying, to understand the role of regulatory bodies within the context of medical assistance in dying and how that impacts nurses, as well as understand the role of health authority policy and how that impacts your nursing practice again. I'm going to try and articulate some challenges that have surfaced over the past year within medical assistance in dying and give you a little bit of picture of what that looks like for nurses on the ground and how they're feeling, as well as understand how we as a health authority and other health authorities are trying to move along with that and support you, and also think about future implications for MAID for nurses and patients. So the background, I think that we in British Columbia are quite fortunate to have been going along with this process since the very beginning. It was a little bit harder for the rest of Canada to catch up with us because Sue Rodriguez, who was the initial plaintiff back in 1993, she was from Victoria. So British Columbia has had news coverage about this for a very long time. So she argued that it was her own right to die, but unfortunately was denied by the Supreme Court of Canada in September 30th, 1993. She died in February 2nd, 1994 in her own home with the assistance of an anonymous physician. The next two plaintiffs that came forward to lead to us having this change to the criminal code is Lee Carter on behalf of his mother, Kay Carter, who had spinal stenosis, and also Gloria Taylor later joined that suit. Gloria Taylor had ALS and Lou Gehrig's disease. So the Supreme Court of Canada heard the case for Lee Carter and struck down the Criminal Code of Canada prohibiting physician-assisted death. And then the federal government gave the incoming government 1 year to make the changes. So then in June 17th, which was a little bit after 1 year, the Bill C-14 was passed by Royal Assent on June 17th of 2016. So as Patrick said, we're just a year into medical assisted dying. Kay Carter she died before the case went to court. A lot of people think that she was alive during the proceedings, but she wasn't. And Gloria Taylor she did not have an assisted death. She died of a severe infection in 2012. So yeah, that's that. So now that it is now legal, it's been illegal for about a year and a bit for people with advanced stage of people in an advanced stage and irreversible decline whose death is reasonably foreseeable and experiencing physical or psychological suffering to receive physician-assisted death, medically assisted death. There are three populations that were identified and purposely left out within the Criminal Code to be explored later. So the Canadian Council of Academies has been asked to look into these three areas, and so those three populations are mature minors using use of an advanced directive to indicate that you would like to have an assisted death, and people who only have a diagnosis of a mental illness. Patty Rodney, who has been very involved with the ARNBC, is on that special council. There's 45 very distinguished members, and she's one of the people that is going to be discussing that on behalf of Canadians. So that's very exciting for ARNBC. So now we're going to talk about who is eligible. So this is just who is eligible, and nurses who are listening, you don't necessarily need to be telling patients whether they are eligible or not, unless you're a nurse practitioner. This is just good information for you to have. So please don't feel like you need to remember this and be able to regurgitate this to patients. So patients need to be eligible to receive health care within Canada. They also need to be at least 18 years of age. Because this is a federal statute, despite the fact that the age of consent in British Columbia is 19, we still need to address patients with requests age of 18 and up. The patients also need to make a voluntary request for medical assistance in dying, which is facilitated by them completing a patient request record. This is the same piece of documentation for the entire province, which was very, I think, good job, Ministry of Health in British Columbia, because patients, if they start their journey in Northern, then they can move to Interior, if that's what they want. They don't need to redo the process. They need to have given informed consent after being informed of all the means available to receive their suffering, including palliative care. There's a large myth out there that the patient has to have tried all the different kinds of things. That's not true. The patient just needs to be aware of them as a potential care option. The patient also needs to have a serious incurable illness, disease, or disability. Again, there's another myth that the patient needs to have a terminal illness. That's not true. It just needs to be deemed incurable. The patient also needs to be in an advanced state of irreversible decline in capability. So capability, what does that really mean? That's up to the assessors to determine. But basically, what we think the criminal code was meaning was that their health needs to be going up and that there's not the potential of their health coming back to life, basically. Their death also needs to be reasonably foreseeable. A lot of people were frustrated by that terminology, reasonably foreseeable. What does that mean? Some people think that my death is reasonably foreseeable. I'm 35, but I probably wouldn't be deemed to have foreseeable death. So again, it's up to the assessors to determine what reasonably foreseeable means, and that's up to them to determine within their own clinical practice. The patient also needs to be enduring physical or psychological suffering that is intolerable to them and cannot be relieved by any means that they deem acceptable. And this is important to remember, that this is the patient determining if they're experiencing suffering. It's not our version of if we think that a patient is experiencing suffering. So just like with pain, when patients, I think it's pretty nurses are pretty good now at accepting when a patient says my pain is 7 out of 10. Same with suffering here. We would like to just acknowledge and believe the patient that they're experiencing suffering, despite the fact that we may not see it on the outside. A lot of after the criminal code came out, there was a lot of people that were frustrated by it because they felt like Carter, who initiated the Carter versus Canada verdict, may not have been eligible herself. But as I said before, it's really up to the assessors to determine who's eligible or not, which is one of the major barriers that we're definitely having within British Columbia. Provincial action. So within the BC Ministry of Health, all the health authorities got together since they knew this was going to be a change coming, and I'm pretty proud of the BC Ministry of Health because they were the only Ministry of Health that determined that each health authority needed to have a central location so that each patient could gain access to that medical assistance in dying if their care provider was a conscientious objector. So I think we should be very proud of the BC Ministry of Health for being so forward-thinking. So that meant that each health authority created a care coordination service that needed to have at least a phone number, an email address, and a website so that patients could receive information and have an effective connection with someone. Each care coordination service does this in a variety of ways. They also have, so we all coordinate care and link people with assessors and prescribers in some way, shape, or form. We also work on systems implementation, create care practice documents, policy, those kinds of things. We also try to help healthcare professionals in their own development with this and increase competency, as well as provide education, whether that's just-in-time education or more in-depth education about the process. So, regulatory bodies. There's a lot of regulatory bodies within British Columbia, and but I'm going to speak specifically about the ARNBC, the LPNBC, and the RPNBC. The rest of the allied health colleges are still, all of them have released their statements, whether about medical assistance to dying, and that can be very frustrating for those health providers. So we should be happy that our colleges have been able to release the scope of practice. So there's one major difference that I just want to identify between our RNs, LPNs, and RPNs. RNs and LPNs, their college has determined that it's okay for them to talk with patients about medical assistance in dying if the RN or LPN feels comfortable doing so. It's important to note for RPNs that if a patient says, I want to talk to you about medical assistance in dying, that you cannot say, your college has dictated, that responsibility should be passed to their most responsible provider, and you as an RPN can't facilitate that conversation. I've had a couple RPNs say to me, but I'm also an RN, so in which role am I being in here if I have both of those distinctions? And so I think that's really up to you. If you are hired as an RN in that site, then you can be an RN there, but if you're hired as an RPN, then it's probably better to make sure that you keep your license, and then you can call your college later to ask them about that question. It's also important for all nurses, and not nurse practitioners, but all registered nurses, LPNs, and RPNs, that we cannot introduce this as a care option. So if a patient speaks to you and says, hey, I want to know about medical assistance in dying, physician-assisted death, physician-assisted suicide, that pill that someone takes in order to end a patient's life, it's clear that that patient is aware that this is a care option they could receive. If the patient says to you, I just want to die, we as registered nurses, LPNs, and RPNs cannot initiate that care conversation. If you think it's something that the patient could potentially benefit from, it's important that you tell their most responsible provider. So that distinction was made within the criminal code, but reiterated with all the regulatory bodies. Having said that, we would still like all of our nurses to support their patients and families throughout the process. And just because they're going through the process of medical assistance in dying doesn't necessarily mean that we stop the rest of the care. Because at any point they could say that they don't want to proceed with it. So we need to make sure that they're still having their care plan proceed. Conscientious objectors were recognized by the Criminal Code of Canada and all the colleges, and that conscientious objection is seen to. So we want to support any conscientious objector with the fact that they feel like they don't want to provide, not provide care, but provide information, no problem, or be involved with a direct process. But you still, if you're a conscientious objector and you feel like you can't care for your patient, we hope that you do still care for your patient and still hand them the ice chips and continue their daily bath. If you feel like it's too much for you, it's important that you remember that you have a duty to transfer care and that you need to still care for that patient and complete their care plan until their care is transferred. All nurses have a duty to document their care. There's some myths out there that because if you're in a non-participating faith-based institution, that you shouldn't document the care or what the patient is talking to you about. That's not true. Your regulatory body supersedes any policy that you have, so you always have a duty to document, and then your institutional policy lies underneath that. Another thing that ARNBC mentioned is that there is education needed for anyone that's inserting an IV that will be used for an assisted death, so that if the patient has no IV access whatsoever, and then we need to go insert an IV. So that nurse needs to have additional education. They didn't necessarily say what that meant by education, they just said they need it. If there's already a pre-existing IV that's patent, then we don't need to go back and educate the nurse that inserted it. We will just use that IV that's already there. And all RPNs, and this is a pretty big point, all RPNs, RNs, and LPNs do not draw up medications. We don't administer the medications or document the medications that were used for an assisted death. We also don't flush lines or pronounce death. I know this is definitely within our normal scope of practice within most medications, but with medical assistants in dying, we don't do it. Okay, I'm going to quickly talk about ARNBC NP scope of practice. So I think it's pretty significant and pretty amazing that we're the first country in the world where nurse practitioners are prescribing and administering medications that still will end a patient's life. So yay, nurses. The nurse NP has the duty to inform their patient about medical assistance in dying as a care option or make an effective connection. And this is really similar to the College of Physicians and Surgeons of British Columbia. The majority of the things to follow are pretty much the exact same as the College of Physicians and Surgeons. The NPs can either act as assessors or prescribers, which is really great. ARNBC has asked that NPs create a preceptorship, complete a preceptorship, but they didn't really say what that meant. So it depends on your health authority and your institution that the NP is working in to determine what that preceptorship looks like. So prescribing NPs must, if they're the prescriber, they must be there and present during the administration of the medication, either IV or oral, and stay with the patient until the death and pronounce the death, complete the medical certificate of death, and complete all that paperwork. The reason this is different is in other places where there's assisted death, where the patient just drinks it, the prescriber hands them the medication and then leaves. Within British Columbia and pretty much the majority of Canada, if you prescribe the medication, then you need to stay there until the patient has an assisted death. Unlike the College of Physicians and Surgeons, the NPs do not need to report that they're doing this, including this in their practice to their college. The college says that they support them and hope that they will stay within their scope of practice. Okay, so now we're going to quickly talk about health authority differences. So health authorities, as I said, there's your college, which you need to make sure that you continue all your practices based on your colleges, and then there's your health authority policy that is dictated underneath that. So health authority policy dictates the level of involvement for each professional. For instance, in Vancouver Coastal, we have asked that only registered nurses be the one to insert the IV that will be used for medical assistance in death. Despite the fact that LPNs could potentially do it and have that in their scope, right now we're just sticking to RPNs. Each health authority has determined what they think involved means to define it for conscientious objectors. The majority of them is exactly the same, saying that involved means that you are included in discussing medical assistance in dying, that you're there for the assessment or the actual provision, or if you're a pharmacist, obviously dispensing the medication. Some health authority policy dictates the location of the assessments or provisions. So that could be if you, let's say, are on Providence healthcare sites, that you, some of those sites, the patient needs to leave for assessments or provision or be transferred out altogether. I think at Fraser, it used to be that patients would go to a specific site in the community for the patients to receive an assisted death, but that's not, I don't think that's necessarily the case anymore. I think that policy is changing. These policies are always changing because it's just so new. In Fraser Health also, they have a policy that superseded the existence of medical assistance in dying that said that no staff could act as a witness on any type of request form. So that policy, that's not the case for Vancouver Coastal or I think for the island, but that's something that you would have to look into if you're going to support your patient through the request record. I've talked a little bit about care coordination services, but each care coordination service would like to provide as much education as we possibly can, but it obviously is going to be different based on the health authority availability, the urgency of the request, and the location of the request. Northern, I think, has a pretty massive area that they need to cover, so I think it's hard sometimes for the care coordinators to necessarily get there. In specific to each health authority, there's different barriers that we have. So on the island, they have lots and lots of numbers, but their number of prescribers is slightly higher than the rest of the health authorities. But they also have a very large area that they need to cover. So the number of availability and location of assessor prescribers is different for each health authority. And each health authority care coordination service has a variety of different supports for pharmacy, supplies, and IV support for provision, and that's just based on really. So this next slide looks at just Vancouver Coastal requests and death, and if you can just keep this information to yourself and to fellow nurses, but we're not going to be reporting this to the rest of the public. So I'm going to speak specifically about Vancouver Coastal requests and deaths, but the trend that you see there is pretty much the same for all of the health authorities. So our requests are only going up, and which is that's kind of what we thought was going to happen. So for Vancouver Coastal, our deaths are about 2% of all the deaths within Vancouver Coastal, and for VHA, it's about 3% of all the deaths, and that's pretty close to what it's been like for Belgium and the Netherlands. They don't necessarily have the same kind of eligibility criteria. Theirs is a little bit more broad. Oh, sorry. So yeah, their inclusion criteria in Belgium and Netherlands is that they also allow people with a mental illness to potentially receive it, and they also have it as advanced directives. And their numbers are about 4 to 5%. Our numbers in British Columbia are ranging between 1 to 3. So we're slowly getting there, and we're only a year in, and they've had it since 2002. Okay, so the process, I don't know how quickly I can go through this, but I do an entire talk on this one slide, so if you have questions, that's really reasonable, but we're going to hold it to the end, and then we can talk about it then. I think a way that you can help make this become real for you is think about a patient who is potentially might benefit from medical assistance in dying, and think about how you would support that patient through each stage. So the first stage is where the patient is requesting information and understanding all their care alternatives. This is the stage where patients may say to you, what's that physician-assisted death thing? And so then it's important that you remember what your role is and that you can't introduce new care options unless you're an NP. The second stage is contemplative, which is where the patient has determined that they would like to go through with the request. So this is when they complete the patient request record. There's lots of things, stipulations about who can and can't be witnesses, including you can't be a care provider, you can't be an owner or operator of the site, and you can't be a beneficiary of the will, either financial or material. So even if the person is getting their grandpa's favorite coin or their rug, then they still can't be a witness. There's a lot of people from Dying with Dignity across British Columbia that are supporting patients complete those patient request records. So when they complete that, that's day 0, and then it moves on to the assessment stage. So the determination is where the assessments take place, and that's usually that's the time of reflection. So day 1 to day 10 is the time of reflection, and that's when the assessors go and see the patient. If the patient is found eligible on day 11, is the first day that they could potentially receive an assisted death. We can abbreviate the timeline and make it shorter if both assessors and the patient feel like the patient may die in a manner that they don't want or lose capacity to consent. The fastest that we've done it in Vancouver Coastal was 7 hours, which is really quick, and that was obviously not great. We don't like to do it that quickly. We also have patients who completed a patient request record back in August but still haven't had an assisted death. So the requests don't expire and the assessments don't expire unless the assessor determines that it expired and wants to complete a new assessment. So the actual action phase and planning is when a patient has said, okay, I would like to die September 10th at 2 p.m. So then we try to make sure that there's an IV support nurse that's ready. There's the prescriber is also available. That funeral home arrangements have been made, and that what else is needed? That the family is there if that's what the patient wants. Oh, and medications. So there's a lot of stuff that happens on that day, and it can be obviously really traumatic, but I think the prescribers are getting pretty good at supporting the patients through that experience and family members. And then after death care is pretty normal. So this is a coroner's case, but the only part of it that's the coroner's case is the paperwork. So the medical certificate of death is completed by the prescriber, and then as the supporting nurse, you would help the family with any funeral home arrangements or any additional bereavement care that you have available. The patient can be washed as they normally would. You can remove lines, and they can go down to the morgue before the funeral home as is normally planned. All right. Now we're going to talk about nursing implications. There are so many, and we only picked 8 or 9, but the nursing implications are vast. And I think one of the biggest ones that is that it's just adding another layer of complexity to the death and dying process, which is already so nuanced and really complex already. It's also really strange to have this new care provider come in and discuss medical decisions with a patient that you don't know, because you gain the trust and respect of the people that work around you, and then all of a sudden you have this stranger coming in, because a lot of the times the assessors aren't necessarily someone who is known to the patient because this care option is so new, and not many physicians and nurse practitioners would like to include it in their practice yet. So that's really hard. There's also no current system of communication standardized within the health authority, well, in particular my health authority, to inform people in communities and residential care settings and assisted living facilities that this is what's happening with their patient. Also, patients can still maintain confidentiality. If they don't want you to know this is what's happening to them, and then one day you come and they passed away. That's quite alarming. So we recognize that that's big. Nursing are also slowly learning their role and how to support their patients, and because it's new, at the Care Coordination Services, we're trying to support you, but it's also really hard. I want to acknowledge that there's a lot of moral distress around this, and not just for conscientious objectors. Just because you don't think this is morally right, you may not think, I've had nurses tell me, he's lying in the bed, he's looking so happy and smiling and having fun with his family, he shouldn't be eligible. And that's just our opinion, but if he's been assessed by 2 people and found eligible, we just need to trust their judgment and that they've done their due diligence. But that's still morally distressing. And that nurses may receive a transfer for a patient from a non-participating faith-based institution, which is really hard. Nurses in those non-participating faith-based institutions are upset themselves that they have to relinquish care to another care team because they want to support their patient as well. So it's hard on both sides. Nursing practice definitely varies across health authority and institutions based on what it is. So we're still trying to figure out what exactly nursing practice means in relation to medical assistance and death. And then there's this sticky slope around patients remaining competent versus providing symptom management. So sometimes we know the patients need to provide consent right before they receive an assisted death, but then I also the patient's saying that they're in so much pain. But if I give them morphine, will I mean that they're going to lose capacity? And it's really tricky. So we're not quite sure if we can support you in creating care practice documents to support that. But I think the best thing is just to, if that's happening for you, reach out to your care provider and to the provider of medical assistance in dying, and maybe we can move the time forward, or we can change that order to make it not 24 hours and make it a short-acting medication. Okay, implications to patients. Again, there's hundreds of these, but these are the main bullets, is that it's a new care option that's not fully understood by staff and physicians. So there's so many myths out there that are leading patients, physicians to not necessarily offer it as a care option or think that they need to offer it as a care option. There's also a lot of myths out there that physicians are telling patients that make them not want to go through with an assisted death. There's one patient that told me that their physician said that there needs to be the 2 witnesses, and then those 2 witnesses need to be there for each assessment and the provision, which made the patient say, I don't want to go through with it, and that's obviously not true. So that's something that the care coordination services are trying to tackle. There's lots of patient wishes that may not be guaranteed or fulfilled. So a patient may want to die, but they may not be found eligible, which is also really hard. Also, the patient may deteriorate out of capability and then may not be able to receive an assisted death, which is also really hard for patients and families. And the request for medical assistance in dying may increase the complexity of family dynamics, because maybe some family members are okay with it, maybe some family members aren't okay with it, and then what do we do and how do we support those family members? That's definitely tricky. Patients may have to leave or be transferred out of their current location to receive assessments or provision, which is really distressing for patients. So challenges. I kind of alluded to a lot of them, but there's varied access to medical assistance in dying for patients based on the knowledge of their current care provider and the knowledge of their family members around them, and also based on location of where they are. If they're in the Northern Health Authorities, can sometimes take weeks to have an assessment. There's a denominational healthcare agreement, which I've kind of alluded to, but it's the thing that it was signed in 1996 and allows faith-based institutions to determine what care options they can provide, and they don't need to provide care that's morally objectionable. So that is, in Providence Healthcare, for instance, that is providing abortions, Plan B, birth control, and now medical assistance in dying. The ambiguous legislation has led to varied interpretation, and that's really something that we're working with the College of Physicians and Surgeons to figure out if we can create care practice documents to help create some guidelines, because some patients may be accepted by one assessor and the other assessor thinks that this patient is in no way eligible. So we see different variety. Nurses and allied health are definitely struggling. They can't initiate this as a care option conversation. I, as a nurse, I would love to tell a patient that they could potentially receive this, but I think it's important to stay within our college guidelines for now, and until it becomes a practice within Canada in about 4 or 5 years, then maybe that can be expanded. But right now, we've got to stick within our college. It's definitely distressing for everybody involved, so not just to the patients or the family members. It's hard for everybody, and so it's just important to use the methods that that are available to you to ensure that that your distress is addressed. I've also talked about a lot of myths. I had one person think that if you receive an assisted death but you didn't have a do not attempt resuscitation order, that we would need to revive you after you had that, which is obviously not true. So then the patient was told that and is very distressed. So I've just told you about 2 myths of about 1,000 that I've heard, and we know that they are out there and we're trying to get to them. But there's a lot. People just make up a lot of interesting things. There's a lack of resources for patients and family members, and in some people's view, very narrow eligibility criteria. So looking to the future, there's a number. The numbers are increasing for all of the health authorities, and so we're trying to figure out in each care coordination service how we can best address that. We don't know if we can increase staff. We don't really have any money, but we're working on it. The Canadian Council of Academies are going to submit a report back to the Ministry of Health and Ministry of Justice in June of 2018, which is going to look at whether mature minors use the use of advanced directives and people who only have a diagnosis of mental illness could potentially be included in this legislation, and that's really exciting. So we're going to see what happens there. There's also court challenges that are happening in Alberta, Ontario, and British Columbia, which may change those eligibility criteria before the Canadian Council of Academies gets to report back their own findings. So I just wanted to make sure that everyone here had the ability to reach out to their own health authority. I'm able to speak about Vancouver Coastal Health, but I may not necessarily know the most up-to-date information for Fraser, Viha, Northern, PHSA, or Interior. So here you go. And here's some provincial and national resources. If you want to learn more, there's definitely a lot on the Learning Hub. The BC Ministry of Health site is very helpful, and same with the Canadian. Yeah, there's some national things for you to go if you want to go look at them.
All right, thanks so much, Laurel. That was very informative. And just before we go to the questions, I just want to flag this slide to everyone that's online. So as Laurel mentioned, the Council of Canadian Academies expert panel on MAID is the group that the federal government has tasked to further study 3 types of particularly complex requests for MAID. So those for mature minors, advanced requests, and those requests with or where mental illness is the sole underlying condition. And so they put out a call for submissions to the general public, and ARNBC will be submitting a submission to the CCA, and we want to make sure that our submission is as informed as possible by the Nurses of BC. So we have put out a questionnaire on our website that went out today, and it will be available up until August 16th. So if you or a colleague has expertise in this particular area or just interested in providing some information on what you think some of the key issues should be further studied and if you have any key resources that you want to submit to the CCA, please fill out that questionnaire, and we'll be happy to include that information into our submission. So we're just going to go on to the questions, and as I mentioned, if you want to ask a question, please type it into that taskbar on your right-hand side, double-click the question tab, and we'll read it out loud. Just going to expand this. Okay. So the first question is, if the patient has difficult IV access, and they need a PIC or a paraglide, paraglide inserted, does the PIC team need to be educated?
Short answer is yes. We haven't had that yet, but I think that may happen in the future if we determine that a patient may need it yet.
And this one's from Joanne and Catherine from ARNBC. They have a couple questions. Oh, they were just wondering if we're going to be addressing at the end. So the question is, first use of term euthanasia. At ARNBC, we do not use this term. Is it in use in the health authority?
To my knowledge, no, we're not using the term euthanasia. We're using medical assistance in dying. But the reason I mentioned it at the start of the webinar was just to be clear, because I think that there's some misconceptions about what euthanasia is, so I just wanted to define it.
Okay, thank you. And this next one, Fraser Health Authority makes a strong attempt to provide care for patients at a location of their choice.
Yes.
Options are available for patients in the community who choose to enter into a facility to receive a provision. I guess that was a comment. Yeah, initially
that patients in Fraser were being moved, but I think in every health authority and every institution, everyone is really trying to ensure that patients' needs are addressed where they are. I think that's it.
More questions? Maybe I'll give it 1 more minute. If you have a question, feel free to type it in. So this one's from Joanna at ARNBC. So the question is, so would we say it's medically assisted death regardless of whether an NP or physician administered or it was done by the patient?
Yes. Yeah. So I'm saying a medically assisted death, either if it's physician or NP, or whether they take the oral drug or it's administered. Some patients have wanted me to get down to the nitty-gritty, and then I use those particular terms, but in general, I say medical assistance in dying, by physician or NP.
And we will be sharing this PowerPoint on the ARNBC website. We'll be posting it within the next day or two, so just keep an eye out on the past webinar page on our website. Another question, so why is VCH restricting IV access to RNs? Can you discuss this rationale?
Yeah, so right now, why are we doing that? I think that I'm not going to be able to say really, apart from we just made that determination mostly because we only had RNs helping us at the time, but we are going to look at it in the future.
So what is the reasoning and rationale behind LPNs not starting the IV? And I guess
it's the same thing. Yeah, we're just, right now we're restricting it, and then we're going to open it up in the future.
All right. Any other questions? Going to take one final look. All right, I think that's it. So thanks so much for tuning in today. If you have any other questions, feel free to email them to me, and I can always connect with Laurel and some of the other MAID managers, coordinators across the province, and point you to the right direction. Again, if you're interested in filling out or providing some input into that submission that we're going to put forward to the Council of Canadian Academies, please feel free to do so by August 16th. And if you have any colleagues that would like to watch this webinar and weren't able to make it, do know that we do post it within a day or two on our website, so feel free to check that out. And keep an eye out on further webinars that we'll be hosting. So thank you so much. Take care.